Hello, I'm PhD student Alexander Fagentoft from the Department of Cardiology at Zealand University Hospital in Denmark. On behalf of co-authors and I would like to say thank you for the opportunity to present our study with the title Socioeconomic Position Influences the Risk of First-Time Cardiovascular Event in Patients with Type 2 Diabetes in Spite of Equal Access to Healthcare, a Danish nationwide cohort study. We have nothing to declare regarding this study. First, I will explain the background of this study. So, cardiovascular disease remains the leading cause of mortality and morbidity among patients with type 2 diabetes. Therefore, systematic cardiovascular risk stratification is recommended in order to identify patients in very high risk. These patients may benefit from intensified prevention strategies, whereas patients in lower risk groups may avoid overtreatment. According to the 2019 European Guidelines on Diabetes and Cardiovascular Disease, most patients with incident type 2 diabetes are considered as high-risk patients. Yet, patients with established cardiovascular disease, target organ damage, or 3 or more major risk factors are considered as patients in very high risk. So, inclusion of other markers may help to optimize this risk stratification. In this context, socioeconomic position may be a good marker to identify disadvantaged patients. In the general population, socioeconomic position has consistently been associated with a higher incidence of type 2 diabetes, myocardial infarction, and stroke. However, no large or nationwide cohort study has examined the association with first-time cardiovascular event in patients with incident type 2 diabetes. This is of particular interest to investigate in Denmark, since the Danish healthcare system offers free and equal access to healthcare for all residents. Therefore, our aim was to examine the association between socioeconomic position and first-time adverse cardiovascular event in a Danish nationwide cohort of patients with incident type 2 diabetes. So let's take a look at the methods. In Denmark, all residents are provided with a personal civil registration number. This number enables individual level linkage of nationwide registers. So in this nationwide observational cohort study, we used these 6 different registers to obtain information on date of birth, sex, cohabitation status, and vital status, hospital admissions, medication, cause of death, income, and educational level. For the study design of this study, we identified all Danish residents with incident diabetes. This was defined as a first-time redemption of a glucose-lowering drug or first-time diagnosis of diabetes in the period from 2000 to 2017. In order to exclude patients with possible pre-existing, non-clinical recognized ischemic heart disease, the study entry date was set to 90 days after diagnosis of diabetes. We excluded patients with type 1 diabetes since we excluded patients younger than 40 years of age. Moreover, we excluded patients older than 79 years of age, or with the prior history of ischemic heart disease or stroke. As a proxy for socioeconomic position, we examined quartiles of inflation-adjusted 5-year mean equalized disposable income. This is a measure that takes family size, family total income, and wealth into account. Concerning the outcomes of this study, the primary outcome was first-time adverse cardiovascular event, or MACE, consisting of myocardial infarction, stroke, or cardiovascular mortality, whichever came first. The secondary outcomes were the first-time occurrence of the individual components of MACE. Concerning the statistics of this study, we reported the standardized absolute 10-year risks of all the outcomes based on core-specific Cox regression models adjusted for potential confounders. Moreover, we reported the 10-year risk differences using the highest income group as reference. So let's take a look at the results for this study. This flow diagram shows the selection of the study population. First, we identified around 220,000 patients with a first-time diagnosis of diabetes between 2000 and 2017. After applying the exclusion criteria, we included around 107,000 patients in the final study cohort. Now for the baseline characteristics. These characteristics are illustrated in this table according to quartiles of income, with the lowest quartiles in the first column and the highest quartiles in the fourth column. As compared with higher income groups, patients in lower income groups were older and more likely to be female. They were less educated, more likely to live alone, and in general they had more comorbidities, and they were less likely to receive treatment with statins and RAS inhibitors, but more likely to be treated with antithrombotics, loop diuretics, and insulin. Looking at the absolute risks, this plot illustrates the standardized absolute 10-year risk of MACE according to quartiles of income. The horizontal axis shows the time since study entry. As illustrated at the plot, quartiles of income showed an inverse association with the 10-year risk of MACE, with the highest 10-year risk of 23.7% in the lowest income group, as illustrated by the red curve, and the lowest 10-year risk of 17.5% in the highest income group, as illustrated by the green curve. When compared, there was a significant risk difference of 6.2%. Looking at secondary outcomes, the same inverse pattern was observed. For cardiovascular mortality, we observed a risk difference of 4.5%, and for myocardial infarction, there was a significant risk difference of 1.7%. For stroke, this risk difference was 2.1%. At this slide, the 10-year risk differences for all the outcomes are depicted in the forest plot. As illustrated on the prior slide, we observe socioeconomic differences on all the outcomes. We're looking at the individual components of MACE. These risk differences were most profound for cardiovascular mortality. Yet, our study has some limitations, and the most important ones are as follows. First, the definition on diabetes relied on discharge codes or prescriptions of glucose-lowering drugs. Therefore, we may not have included some patients with diet-treated type 2 diabetes. However, both methods have been validated with high positive predictive values. Second, the outcomes relied on discharge codes, and we cannot rule out potential misclassification of the outcomes. However, discharge codes of myocardial infarction and stroke have also been validated with high positive predictive values. Third, we cannot rule out residual confounding, as we did not have information on behavioral or biological cardiovascular risk factors such as smoking status and A1C, yet we adjusted for accumulated comorbidities prior to study entry. In conclusion, low socioeconomic position was associated with significantly higher 10-year risks of first-time cardiovascular complications in patients with incident type 2 diabetes. This was observed independently of accumulated comorbidities and in spite of equal and free access to healthcare. Therefore, socioeconomic differences in other countries are most likely greater. In a clinical perspective, our results indicate that low socioeconomic position is a very important marker to consider in cardiovascular risk assessment in patients with type 2 diabetes. Thank you for your attention.